Good morning, everyone. Are we enjoying the food and the music? Yes, we're trying something new to calm the savage beast. Good morning. Today we have Dr. Mandy Atkinson, a Pediatric Hematology Oncologist here at Carilion, an Assistant Professor of Pediatrics, and a self-proclaimed Air Force brat, which she's very proud of. Dr. Atkinson trained at Columbus Children's Hospital and did her fellowship at St. Jude's. She serves on various committees here at Carilion and is a medical advisor for the Make-A-Wish Foundation. Please welcome Dr. Atkinson.
Good morning. So today I'm going to talk to you about pediatric ITP, or immune thrombocytopenia purpura. I have no disclosures. So my objectives are for you guys will understand the natural history of childhood ITP, recognize the clinical presentation, know that most cases of pediatric ITP do not require therapy, understand that most cases of ITP do not require admission to the hospital, know the indications for treatment of ITP, understand the benefits versus risks of first-line therapies, and be able to treat emergency bleeding in children with ITP. We're all going to know how to do all these things by the end of the talk. So ITP has sort of changed its name over the years, starting with immune thrombocytopenia purpura, then it went to idiopathic thrombocytopenia purpura, and now we're back to immune thrombocytopenia and adding the purpura. So we're going to start off with the case of the bruised toddler. This is a 3-year-old boy who woke up that morning covered in bruises. He was perfectly fine the day before, had a cold about 2 weeks ago. He goes to the babysitter during the week, a rough and tumble kind of toddler. Mom took him to the primary care physician, and CPS was called for suspicion of abuse. And this was him. This is an internet picture, so I'm not going to get in trouble. This is what he looked like. And those were his legs. And you notice the distribution isn't really suspicious, but the bruises on his face probably are a little bit more so. And his attitude probably didn't help the situation. All right, so his exam showed extensive bruising on an otherwise well child. His vital signs were normal for age. He didn't have any lymphadenopathy and no hepatosplenomegaly. He was active around the room with apparent normal mental status for age, crazy and running around. His CBC, PTT, factor 8 and 9 levels were sent. So what do you guys think about those labs? Does that seem like a good workup? Any comments?
Why did he need a factor 8 and 9?
Yeah, so that's a good question. Typically, we do not get factor levels when we see children with bruising. A PT, PTT are going to tell you basically what you need to know in terms of factor levels. And really, if you, the big test for ITP is just a CBC. We'll go through that in a little bit. So his platelet count ended up being 8,000. His white count and hemoglobin were normal, and his smear showed normal white and red cells, but very few large platelets, which is sort of the hallmark for ITP. So this here, can you guys see that? Yeah. So this is a large platelet. Remember, platelets are just like big little bags of granules, okay? So this is, I don't have a red cell in this picture, but it's almost the size of a lymphocyte, so that's pretty big for a platelet. Sorry, it's bigger than a red cell. These are red cells. These are red cells. This is a platelet, okay? Normally, platelets are like tiny little speck things on a smear, more like this over here, so you can see how big this is, all right? This is another one. And then over here is a marrow, which shows a megakaryocyte. So in ITP, you should have a normal to increased number of megakaryocytes because your body is destroying them, right? It's not a production problem. So the megakaryocytes are revved up. So his history was consistent with acute onset, bruising, preceding viral infection. His exam showed bruises and petechiae, but no lymphadenopathy, no hepatosplenomegaly. He had isolated thrombocytopenia on his smear, and he had few large platelets without any blasts. This is classic ITP, okay? So we discussed the therapeutic options and current recommendations. The decision was made just to observe. He followed up at 1 week and showed no bruises and healing ones that he had, and his platelet count was up to 36,000. By 2 weeks later, his platelets were normal. This is just what we like to see. If they were all so easy. Dr. Sherman.
Going to eventually talk about whether or not he needed a bone marrow?
Yes. I'm supposed to give you that microphone. So for those of you who didn't hear that question, Dr. Sherman asked, are we going to talk about whether or not eventually he needs a bone marrow? And we'll discuss that later in the talk. I have to thank Dr. Borowitz. She put in these fancy transitions in my presentation, and so half the time I'm probably not going to understand that I have a transition there, so hopefully it's not going to mess me up too much. So the differential diagnosis of thrombocytopenia, the first big category is increased destruction, and the first topic within that is immune. So ITP comes under immune, destruction of platelets, and then you can also have immune destruction secondary to infection, drugs, or vaccinations. Non-immune causes of destruction of platelets would be increased consumption like DIC, HUS, and microangiopathic hemolytic anemia, increased destruction like in hypersplenism, again drugs, prosthetic heart valves, and splenic sequestration. And then there are the decreased production problems. So bone marrow suppression, either hereditary like in Fanconi's anemia, thrombocytopenia absent radii syndrome, Wiskott-Aldrich, which is the hallmark for that is small platelets, and then ameducariocytic thrombocytopenia, so they just don't make platelets. Acquired causes of decreased production would be drugs, chemotherapy, and infections. And then bone marrow infiltration, as in leukemia, metastatic disease that goes to the bone marrow, as well as storage disorders. So just an overview of ITP. It's one of the most common causes of symptomatic thrombocytopenia in children. It's an acquired immune-mediated disorder that causes peripheral destruction of the platelets within the spleen, leading to thrombocytopenia. Typically, that definition is less than 100,000, although I will tell you in children with acute ITPs, usually that number is a lot lower. The stimulus for the immune response is unknown, although oftentimes we will get a preceding history of viral infection, sometimes immunizations, things like that. It affects about 5 in 100,000 children per year. The most common ages are between 2 and 5 years old, and then there's another peak in adolescence. The symptoms are all the result of bleeding. Generally, it's a self-limited illness in children and resolves within about 6 months. Rarely, it's associated with significant life-threatening hemorrhage. About 60% have only cutaneous bleeding at presentation, and then 40% have mucosal bleeding, which we call wet purpura, and I've got some pictures of that. Serious bleeding, which they define as epistaxis greater than 5 to 15 minutes, GI bleeding, or other severe mucosal bleeding require admission to the hospital, occurs in about 3% of children, so pretty low percentage. Intracranial hemorrhage, which is what everybody worries about with this disease, really occurs in only about 0.5% of children. It's certainly the most serious consequence of ITP, and I used to be able to say that I had never seen a child with ITP have an intracranial hemorrhage. And then several years ago, we had a little boy that was admitted to the hospital, and he had other medical conditions, including congenital heart disease, and so he was on aspirin, and I think that's what set him over the edge. I can't remember the specifics of his platelet count right now, but he actually did fine in the beginning. We had given him IVIG, and we're getting ready to send him home the next day, and he had a seizure and was bleeding into his brain. He required an emergent splenectomy and platelet transfusions, and so now I can no longer say that I have never seen a child with intracranial bleeding in ITP, but he was on aspirin, and that's a huge risk factor. So More than 90% of intracranial hemorrhage in children is supratentorial. It may be the presenting feature, or it can develop later. Obviously, the signs of ICH would be headache, persistent vomiting, altered mental status, seizures, focal neurologic findings, or recent head trauma. So risk factors for intracranial hemorrhage would be head trauma. And you can imagine in toddlers, this gets to be a little disconcerting for the parents, especially the rough and tumble kid, like we saw before. You know, they're bumping into things all the time, they're falling, and we used to actually fit all these children with helmets back in the day when they were diagnosed with ITP. We don't do that anymore because the risk is very low and it didn't seem to make any difference. These are usually kids who have more extensive signs of bleeding. So they're not just kids who come in with bruising and petechiae. They're kids who have a lot of wet purpura, they have hematuria, they just look like they're gonna bleed, all right? Usually their platelets are less than 10,000. And these kids need urgent evaluation, including imaging, especially if there was recent ingestion of an NSAID or aspirin, because that places them at much higher risk. All right, so primary versus secondary ITP. Primary meaning that it occurs in isolation, there aren't any other associated diseases. And this is about 80% of cases of ITP in children. Secondary causes mean that they're associated with another disorder, and that's about 20% of ITP cases. It's associated with hepatitis C, H. pylori, systemic infections, autoimmune disorders, lupus being one of the main ones, common variable immunodeficiency, HIV, post-vaccination, and then drugs. We actually follow children who end up having chronic ITP. I usually screen them every 6 months with an ANA to look for autoimmune disorders, and we've unfortunately had a few kids who transitioned into autoimmune disease from their ITP. So ITP, just like autoimmune hemolytic anemia, can kind of be a harbinger for some of these autoimmune processes. So got platelets. It used to be thought that, you know, platelets were all, or ITP was all caused by destruction of platelets. We now know that there is some decreased production within ITP, and the thought is that it just can't keep up. The bone marrow can't keep up with the loss of platelets. So there is a mild platelet production problem as well. So the pathogenesis of ITP, you've got these antiplatelet antibodies that we don't know exactly what causes them. They sensitize the platelets. The platelets then are destroyed by the macrophages in the spleen. And again, we now know that platelet production is also a problem. The clinical presentation, often, again, we get a preceding viral illness. It's a well child with acute, spontaneous, or unexpected bruising. The kids who come in looking sick, typically they're going to have another problem like leukemia. ITP really is in otherwise well children, okay? With or without wet purpura, with or without hematuria, and many times actually these kids have been turned into CPS for suspicion of abuse. Typically the spleen size is normal, and that's important. What do you worry about if the spleen is enlarged, students? Leukemia, right? So this is a classic bruise in somebody who has ITP. They're kind of unexpected related to whatever happened to cause the bruise. They're unexpectedly large and unexpectedly dark. And these are some pictures of wet purpura. I think they're pretty self-evident. So this, you've got several. These I would call palatal petechiae, not necessarily wet purpura. You've got a wet purpura here. So the diagnosis of primary ITP, and these were guidelines that were developed by the American Society of Hematology back in 2011, and they've made recommendations in terms of treatment as well as what you need to do for evaluation of these patients. So this is really a diagnosis that you can make with history and physical exam, and then a blood smear would help. So isolated bleeding, consistent with low platelets and no constitutional symptoms. On exam, you have no hepatosplenomegaly or lymphadenopathy or stigmata of congenital conditions like thumbs and TAR and Fanconi's anemia. CBC shows isolated low platelets, less than 100,000. and the peripheral smear should be relatively normal other than few platelets, and they're big. The bone marrow evaluation now has really become unnecessary in patients with typical features, and they've also shown, we used to worry about, whether to start steroids, do we need to do a bone marrow first to rule out leukemia, because steroids will treat leukemia, and so it becomes more prolonged to diagnosis. So the recommendation is that it's unnecessary prior to steroids or splenectomy or in patients who fail IVIG as long as you have a consistent history and exam. So we rarely do bone marrows on patients with ITP anymore. So in terms of the history, what do we need to ask? We need to make sure that they don't have fever, night sweats, weight loss, right? No evidence of malignancy, leukemia. We need to know if there's any family history of low platelets or easy bruising, because that can be a familial disorder. We need to ask about risk factors for HIV, skeletal or soft tissue morphologic abnormalities, again, going along with things like Fanconi's anemia, which usually presents first with thrombocytopenia. Any history of infections, eczema, vaccines. Why would we ask about eczema? Anybody have any idea? Wiskott-Aldrich syndrome. Good. They have low platelets, but their platelets are very small, unlike ITP where the platelets are large, and it's associated with eczema. And then vaccinations, and we'll talk a little bit more about that. So a little bit about pediatric versus adult ITP. Most cases in children are acute versus chronic, lasting only 4 to 6 weeks. Most cases in adults are chronic, now defined by over a year of thrombocytopenia. Most adult ITP is from antibodies to glycoprotein 2B3A. Most childhood ITP is from antibodies that mimic viral antigens. So new definitions of acute versus chronic, and I actually learned this doing studies for this talk. Newly diagnosed ITP would be defined from diagnosis up to 3 months. Persistent ITP would be 3 to 12 months from diagnosis, and then chronic ITP would be longer than a year. It used to be defined as chronic ITP was anything over 6 months of thrombocytopenia, so that's a big difference. So again, the management guidelines of ITP that came from the American Society of Hematology, and this is interesting because they put these guidelines out in 2011, and then there was a paper that came out in 2016 that talked about the fact that there are a lot of physicians who aren't following the guidelines that were put forth in 2011. So the goal is to achieve adequate hemostasis. It's not to obtain a normal platelet count, right? The problem with ITP really is about bleeding. We don't want to treat a number. So the decision to treat should involve a conversation with the patient if they're old enough, and certainly the parents. You need to consider the severity of bleeding. You need to anticipate any surgeries or upcoming procedures where they would need a good platelet count. You need to consider the side effects of the treatment and then health-related quality of life. We actually have a teenage girl right now who we're following, and she has failed every first-line therapy for ITP. And her parents had stopped her from running, which wasn't really necessary, but you can't do a lot of things when you have ITP and a platelet count less than 10,000, which is where hers runs. You know, if you're an athlete and you play contact sports, you can't do that with a platelet count of less than 10,000. You can't ride roller coasters. You can't ride spinny rides. So for some children, it really impacts on their quality of life, and you need to discuss that in terms of treatment. So the majority of patients with no bleeding or skin manifestations only, so just petechiae and bruising, can be treated with observation alone regardless of what their platelet count is, all right? They can come in with a platelet count of 0, we've seen that many times, and you don't need to treat them if they come in without any overt signs of serious bleeding. A single dose of IVIG, 0.8 to 1 gram per kilo, or a short course of steroids should be used as first-line treatment. And then Winro, now called Rofalac, which is anti-D, may be considered for first-line in Rh-positive, non-splenectomized kids with recognition of possible severe hemolysis. So this is a drug that at least I, from personal experience, used a lot in the past. You can only use it in patients who are Rh positive, because if you think about how it works, it's an anti-D antibody like RhoGAM in pregnant women. And so what it does is it attaches to the red cells, and I'm being simplistic. So the blood filters through the spleen, it takes out the red cells that are much bigger, juicier than the tiny little platelets, and preferentially spares the platelets. So the next logical question is, well, what happens to the red cells? And it can cause a severe hemolytic anemia. I have not seen this in anyone, but there is now a black box warning associated with Rofalac that talks about the possibility of severe hemolytic anemia when you use that. So you want to make sure that the patient isn't anemic when you give them that medication. And for some centers, they don't use a lot of Rofalac because of this, including where Dr. Borowitz trained. So successful therapies may be repeated to prevent bleeding. So for instance, if somebody responds to Rofalac, usually that lasts for about 3 weeks, and then you'll start to see their platelet count coming down again gradually. Once their platelet count comes down again to the point where they're bleeding, or if they're needing procedures or whatever, you can repeat that dose, and typically they'll get the same sort of response. Okay, same thing for IVIG, same thing for short courses of steroids. So sometimes in children who come in who you're really worried about, it's worth it to treat them up front. This is my opinion. It's worth it to treat them up front so that you know if they're going to respond to something, because in an emergency situation, that's nice information to have. Options for people who don't respond to first-line therapies would be splenectomy, rituximab, which is an anti-CD20, and so it attacks the cells that are causing the antibody problem. It also destroys your B cells for the next year, although they haven't seen a lot of infections associated with that. Thrombopoietin receptor agonists are kind of the latest and greatest for ITP, but again, only after they fail first-line treatment, and this is what we're considering starting in our teenage girl who's been refractory to everything. And then more potent immunosuppressant agents, things like CellCept. Excuse me. So if you really need a rapid rise in the platelet count, not like a kid is bleeding out, then you're going to transfuse them platelets, but you're also going to give them IVIG. So this is probably the most rapid acting, and we're still talking 24 to 48 hours. It doesn't happen right away. There's no evidence to support long-term steroid courses in children. There's a lot of toxicity associated with this, and if they haven't responded in 2 weeks, they're not going to respond to steroids, so you just need to wean it off and stop it. Splenectomy or other interventions with potentially serious complications, you really want to hold off for at least a year if you can, because ITP is always going to get better. Your body is always going to realize eventually that it's doing this wrong thing and it's going to correct itself. The question is when. And so if you can wait a year at least and give it a chance for the body to correct itself, that's always better, because you don't want to take a spleen out unless you really have to. So non-medical management of ITP. No aspirin or NSAIDs until the platelets normalize. So obviously both of these medication groups affect platelet function. So you want the ones in circulation working up to par. No contact sports. And people say a variety of things in terms of that. Certainly no football. Usually we'll let them play soccer but not head the ball, and you have to warn them that they could have serious bruises and bleeding. It depends on how. Littler kids, we say no contact sports, but people who are really into their sport, you have to be a little bit accommodating for that. No high-risk activities for head trauma. That's the biggest thing. And again, usually that includes sports. The little kids, we don't want riding their bikes when they have platelet counts less than 10,000 because they're likely to fall. And again, no roller coaster spinning rides because of the shear forces that it puts on the brain, predisposing you to bleeding. For teenage girls who are having periods, their periods are obviously going to be a lot heavier when their platelets are really low, and so oftentimes we'll use hormones to control their menorrhagia. So just a little bit more about the first-line therapies. Again, IVIG, anti-D immunoglobulin, which is Rofalac, and prednisone. So IVIG, we typically give 1 gram per kilo. It goes IV, just like any other time you're going to give IVIG. We pre-med with Tylenol, Benadryl, and usually an antiemetic. The expected time to initial response, again, is still 1 to 3 days, so it doesn't work very quickly. The peak response usually happens in between 2 and 7 days, and then the side effects include flushing, low blood pressure, fever, headache, chills, aseptic meningitis, which you have to warn families about, hives, itching, nausea, vomiting, respiratory symptoms, on and on. Anti-D is dosed at 50 to 75 mics per kilo as a slow IV push, so it's nice because you can just butterfly it in as a slow push, especially in kids who have trouble getting an IV. We also pre-med with Tylenol, Benadryl, and an antiemetic. Again, only in Rh-positive people. You want to make sure they have a negative Coombs, and you don't want them splenectomized, otherwise it's not going to work. You also want to make sure they're not anemic, which we talked about. The expected time to initial response is, again, 1 to 3 days. IVIG has a little bit of a time advantage. And the side effects include intravascular hemolysis, which, again, is the black box warning, fever, flu-like symptoms, and headache. That usually only lasts for about 24 hours. So prednisone, I think most of us are aware of side effects of steroids, but for those of you who aren't, the dose of prednisone that we use is typically 2 milligrams per kilo per day, and the recommendation is that you continue that dose for 2 days and then you taper over 21 days. There are kids who have a whopping platelet count by 1 week, and we wouldn't give that dose for another week. We would start tapering them at that time. The peak response for platelets is 7 to 28 days, although certainly you can see a response sooner than that. And then side effects include flushing, edema, Cushing syndrome, hypertension, headache, pseudotumor, gastritis, weakness, glucose intolerance. The efficacy of first-line treatments are about 75 to 90%. The timing of the response is variable and depends on the treatment. For poor response to initial therapies, you can actually combine therapies. So you can give IVIG and steroids or Rofalac and steroids. I've never heard of anybody giving Rofalac and IVIG, but you can combine them with the steroids. And oftentimes that will work when the one medicine alone did not. About a third of patients who initially respond to treatment will relapse within 2 to 6 weeks with patient platelets less than 20,000. And if you think about it, all of these therapies, they're just temporizing the problem. They're not fixing the problem. So as soon as that medicine wears off, this antibody's still there, so it's going to start attacking the platelets again, and you're going to see your platelets count start to go down. Second-line therapies, rituximab, high-dose dexamethasone, immunosuppressive agents. Some people actually use chemo, typically vincristine or vinblastine, which are kind of easy drugs for an oncologist, but obviously not for a patient and their family. It's still chemo. Androgens have been used, and then, again, more recently, thrombopoietin receptor agonists. So a little bit about splenectomy. For those with chronic or persistent ITP who have bleeding and lack of response or intolerance for other therapies and or who need improved quality of life, you would consider splenectomy. Again, you should really try and delay this for at least 12 months, but the response rate to splenectomy is pretty good, about 70 to 80%. The expected time to initial response is 1 to 56 days, so it can take a while. The peak response is 7 to 56 days. The side effects include infections, thrombosis, and lack of response. This is a big deal. You really don't want to do this, especially in children. Adults with ITP get their spleens taken out a lot more often than children do. So management of life-threatening bleeding. This is what we're all worried about in patients with ITP, especially those with platelet counts less than 10,000. So the first thing you would do is actually give them platelets. You don't want to give platelets unless you have to, because it's kind of like adding fuel to the fire, right? The platelet itself is what's causing the antibody production. So if you give more platelets, you're going to produce more antibody. That's the concern. With life-threatening bleeding, you're stuck. You kind of have to do it. You also want to give IVIG, 1 gram per kilo for 1 to 3 days, depending on the bleeding, plus Rofalac if you need to, 75 mics per kilo, so the higher dose, plus steroids, 30 milligrams per kilogram per day of methylprednisolone, IV up to 3 to 4 days, and consider emergency splenectomy. Also consider thrombopoietin agonists. So once these kids have life-threatening bleeding, you're really worried that they're going to have it again, okay? So you kind of want to throw everything under the sun at them. So management of intracranial hemorrhage would be the same as management for life-threatening conditions. Interventions to reduce intracranial pressure, and then you would consider antifibrinolytic agents like Amicar or tranexamic acid. These are medicines that stabilize the fibrin clot so that it gives more time for the tissue underneath to heal before the scab comes off, and those sometimes work. So definitions of response to treatment. A complete response would be defined as platelets greater than or equal to 100,000 measured on 2 separate occasions 7 days apart, and they don't have any more signs of bleeding. That would be a complete response. A regular response would be platelet counts over or equal to 30,000, and again, on 2 separate occasions, 7 days apart, and no bleeding. No response would be a platelet count less than 30,000 on 2 separate occasions and no bleeding. And then you can have loss of a complete response. So they can initially respond, and then the platelet count is less than 100,000 on 2 separate occasions and or bleeding afterwards. Loss of response would just be a lower platelet count. And they use these definitions in terms of, what to do. So again, some more definitions of response to treatment. Corticosteroid dependence would mean the need for ongoing or repeated courses of steroids to maintain the platelet count greater than or equal to 30,000 or to avoid bleeding. Severe ITP would be defined as clinically relevant bleeding, enough to mandate treatment at diagnosis or by the occurrence of new bleeding symptoms requiring additional interventions or an increase in the drug dose. And then refractory ITP would be severe ITP when you've already had a splenectomy. And a lot of adults end up in that situation. So further considerations would be routine testing for H. pylori in asymptomatic children. We used to do this, especially if they had GI concerns, and now the recommendation is that you don't have to do that unless they're symptomatic. They just haven't shown that it makes a difference in terms of treatment. And then there's MMR related. So the MMR vaccine is known to cause ITP. Certainly not in everybody, but there's a small percentage of children who will get ITP in response to the MMR vaccine. And I have a case about that a little bit later. So back to the bruised toddler. Let's say that during the observation period, he develops a nosebleed that lasts 15 minutes. If you remember, that meets the definition of severe ITP. So at that point, we decide to treat him. So the question is prednisone versus IVIG versus Rofalac. What would help you guys decide? There's no hematologist in town. What are you going to do? You can't send him to UVA.
I think earlier you said that IVIG had the most rapid response, so typically that sounds like one of the first things you would do.
Yep.
If they were Rh negative, then the anti-D wouldn't give any value.
So certainly the age would be a criteria. Whether they're Rh positive is going to help you decide. If he was Rh negative, you wouldn't have Rofalac as an option, so your options would be prednisone versus IVIG. Sometimes it's hard to get a toddler to take a steroid because they taste awful, but it's a lot easier for the families, and so, it just depends on, you'd have to have that conversation with the family and going through the side effects. So this is a case of a 6-year-old non-responding soccer player. So they were diagnosed 6 months ago, continues with platelets of less than 20,000, had no response to IVIG or anti-D in the past, and initially she was responsive to steroids, but more recently has become less and less responsive, and that happens fairly often. Develops troublesome nosebleeds, which send her home from school, so she's missing school, quality of life issues, right? And parents want to know if she can return to soccer because she needs to be more active. So what are you going to do with this kid? Other than smack her parents. So what treatments should be considered? She's not responded to anything, right? So rituximab would be a choice for children and teens with ITP who have significant ongoing bleeding despite anti-D, IVIG, or steroids. It can also be considered as an alternative to splenectomy in kids with chronic ITP, but again, you really want to try and give that a year before you do it if you can. High-dose dexamethasone would be another choice, and then it can be considered as an alternative, again, to patients who don't respond to splenectomy. So when should a splenectomy be considered in this patient? You usually really want to try and wait a year. Can she play soccer? Probably not. Although, again, depending on how important it is, you know, if you really counsel her and she seems to be a responsible teenager and she knows what the risks are, as long as she doesn't head the ball, she's probably going to get big bruises on her legs. Oh, I'm sorry. Okay, if she was older, yes, I totally forgot about that. Yes, if she was older, I would consider letting her play. If she's 6, I would not. TJ.
Having watched a lot of competitive soccer, I'm more worried about the big kids. It's a contact sport.
It is a contact sport. They would have to be very careful about not letting them get hit in the head. Again, if you tell them the risk, I mean, there are families and children who are very driven. I mean, you can imagine a soccer player who's in their senior year, coaches and scouts are coming to watch them play soccer, and they can't play because their platelet count is 18,000.
The more driven they are, the more likely they are to have contact.
So it's debatable, and I think you would get a difference of opinion even amongst hematologists. All right, so the case of those evil vaccines. This is a 15-month-old with 24-hour history of bruising and petechiae and received their MMR shot 2 weeks ago. On exam, has small bruises and scattered petechiae, no lymphadenopathy or hepatosplenomegaly. The platelets are 8,000 with normal red and white cells, and the smear is consistent with ITP. So what do you tell the mother about future vaccinations? Children with history of ITP who are unimmunized should receive their first scheduled MMR, all right? If they've already been immunized, then you should check titers. If they're immune, no more MMR vaccinations. If it's inadequate immunity, then you would re-immunize them with MMR at the recommended age, but counsel them on the fact that the ITP may return. So ITP is all over the internet, and I always warn my families, it's kind of like cancer. There's a bunch of websites out there, drink this miracle drink and it will improve your platelet count for only $100 a month. There's all kinds of stuff out there with ITP in terms of, you know, focusing on families who are desperate to help their children. So this is not one of those sites, but this is Today I Sport Purple for ITP awareness. So it's out there for ITP. This is an app on your phone that you get to track your ITP. So you can put in your platelet counts and your medications and all this stuff into this app. How to increase a low platelet count? By eating these specific foods: papaya, pumpkin, spinach, lots of vitamin C, Indian gooseberries, beetroot. And the kids are going to go, blah, and then have a hemorrhage because it's vomiting. And really, in the end, you just have to keep calm and beat ITP. Don't let these kids panic you. So just a little bit more about, you know, admission for these children. Typically, this is something that we would see and treat in our clinic, all right? But about a third of the time, these are the calls that you get on a Friday afternoon at 5 o'clock, and the pediatrician has seen the kid earlier in the day and is worried, so they've obtained a CBC, And that platelet count comes back at 8,000, and they say, go to the emergency room. And then I get a call from the emergency room doctor saying, what do you want me to do with this kid? You know, they've already kind of panicked the family because they're panicked, not to say that all ED doctors panic, but this is a typical scenario for us. And so then we end up admitting them to the hospital because the family's nervous and they need an explanation, basically. But this is not something that we would typically manage as an inpatient unless they have serious bleeding, okay? So if this kid shows up in your office and it's a reasonable time, call us and we can walk you through. If it's time, we can see the child in our clinic. Sometimes we can wait until the next day to see them and discuss everything as long as it's not a real nervous family. Other times we'll have to admit them more just to sort of calm the family down and make sure everything is okay. And then we could discuss treatment and start it if they end up getting admitted. I'm ending early. Any questions about anything? Dr. Sherman, get the
If you'll let me, I'd like to make 2 comments about newborn medicine in this issue. One of them is, as Mandy said, splenectomy is common in adult. An adult woman who's had a splenectomy and now has a normal platelet count is under no risk, but her baby is.
Yeah.
And so that is
the mom with ITP.
Yeah. So she's got antibodies that cross the placenta. The baby has isoimmune thrombocytopenia. So you just need to check a platelet count. If you get that history, even the mother is fine. And the other immune thrombocytopenia in the newborn period is like Rh sensitization, where the mother's been sensitized to a platelet antigen that the dad has that she doesn't have, and her baby comes out and it has petechiae. There's no way to suspect this, but the next time she gets pregnant, you better think about it. And
that's much more of a problem than maternal ITP.
Yeah. But both of these things require a platelet count before you do something like circumcising the baby. Correct.
Any other comments, questions?
You mentioned briefly the H. pylori thing. Is there an official stance on that in pediatric ITP? Or
the official stance is that you don't have to order it. I've never seen it be positive in a patient with ITP, but there historically was an association. So in kids who are symptomatic,
very brief review of the literature. It's fairly fascinating, the connection between those two. Obviously, it's a less prevalent bacteria in our population, but so is there if the child has reflux, if they have some GI symptoms, we should think about that?
Yes.
Interesting.
Yeah. Well, and there is a lot of, I would think that's the same in children. There are many people who are asymptomatic with H. pylori. It's not going to affect the ITP, as I guess where the recommendation comes from ASH. That'd be a GI problem.
With the ITP that's caused by MMR, does it usually have the same length of course as other ITPs? I'm thinking of convincing a parent to re-immunize if they need it. Are they going to end up treated for that, or is it a shorter course that resolves itself?
It all depends on what the platelet count is and what happens. So it's pretty typical ITP. The stimulus would be the vaccination, whereas in most of the time we don't know what that stimulus is, but you would treat it the same as any other ITP. That's a good question.
Any other questions in the room? I can unmute the phones here real quick since we have some time.
You need to talk slower.
No, you're good.
The conference is now in talk mode.
Okay, if you're on the line, I have unmuted the phones. If you do not have a question, just please put your phone on mute so we do not hear your background conversations and stuff. So does anyone have a question or want to make a comment on the line? All right, going once, go twice. Anybody on the line? Okay. I think you're good. Thank you very much, Doctor. If you are on the line and you wanted to email us a question, you can at outreach@carillionclinic.org. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.